Welcome. Our focus today is a rapid, evidence-based update for the emergency department.
That's right.
Our mission is clear: synthesize the latest approaches for early identification and management of sepsis, really aiming to improve patient outcomes. What's the primary issue we face in early sepsis detection with the common methods we use?
It's fundamentally a problem of sensitivity. Sepsis, well, it's a life-threatening organ dysfunction caused by a dysregulated response to infection. We absolutely know prompt recognition is paramount.
Right.
Because every delay, it translates directly into increased mortality risk.
And often the tool that gets relied on heavily, at triage in the bedside is the quick sequential organ failure assessment, qSOFA. But are you saying relying only on that isn't enough?
It's severely insufficient, yeah. The quick sequential organ failure assessment, it gained popularity because it's fast, it's simple, only 3 variables.
Yeah.
Respiratory rate, mental status, blood pressure.
Mm-hmm.
But extensive data confirms its low sensitivity. It hovers right around 50%.
50%. Wow. So if you're only using qSOFA, you might actually miss half of your early sepsis cases. That number's pretty scary when we're talking about such a time-sensitive illness.
It really should trigger an immediate reevaluation of protocols and institutions.
Mm-hmm.
Clinicians need to move toward screening tools that catch that inflammation earlier, before the organ failure gets too advanced.
So which tools are stepping up? Which ones offer a better sensitivity for that initial sweep?
We really need to be using screening methods like the Systemic Inflammatory Response Syndrome, or SIRS criteria, or the newer National Early Warning Score, NEWS.
Okay.
SIRS criteria, they demonstrate much higher sensitivity, often hitting, say, 80%.
80%. That's a big jump.
It is. And the National Early Warning Score, that NEWS, that's also proven highly effective. It brings in more vital signs, more continuous physiological variables. Studies show it significantly outperforms qSOFA in predicting patient deterioration and identifying those really severely ill septic patients.
But let me raise the sort of inevitable practical challenge here. If SIRS is 80% sensitive, it's naturally going to flag more patients, right? More false alarms. In a busy ED, how do we justify that increased workload compared to the quick qSOFA?
That is the essential trade-off, you're right.
Right.
But we have to think about sepsis risk like a funnel. The higher sensitivity of SIRS or NEWS makes sure we don't miss patients early on.
Okay.
So the actionable takeaway here is that clinicians must use one of those highly sensitive tools, SIRS or NEWS, and then supplement it immediately with strong clinical judgment and rapid lab assessment.
Right.
The goal is sensitivity first, then quick confirmation or exclusion.
That makes sense. Catch everything, then filter fast. Okay, so if we catch it early with these better screening tools, what's the next immediate management step? It used to feel like just pour the fluids in, but that's completely shifted, hasn't it? Let's talk fluids.
Absolutely. Fluid resuscitation has seen a real revolution, I'd say, in the last decade. Current guidelines still recommend starting with an initial crystalloid fluid bolus. That's 30 milliliters per kilogram.
Okay, 30 mils per kilo.
And critically, that has to be given within the first 3 hours for patients showing up with sepsis-induced hypoperfusion or actual septic shock. That's the necessary starting block.
Got it. But once that initial bolus is in, do we just keep pushing fluids aggressively, chasing, a high central venous pressure, or just trying to volume load?
No, emphatically not. The emerging evidence strongly cautions against that idea of just indiscriminate fluid loading. We now know over-resuscitation is dangerous. Well, we're learning that excessive fluid can actually leak into the tissues. It causes edema, it impairs oxygen exchange, and can lead directly to severe organ dysfunction. Things like abdominal compartment syndrome, ARDS.
Acute respiratory distress syndrome. Right. Okay. So we start with the standard 30 mils per kilo, but then how do we define a balanced approach after that? How do we know exactly when to stop or maybe just slow down?
The whole approach has to shift from a static checklist to an individualized, hemodynamically guided titration.
Okay, individualized.
Fluids must be titrated based on dynamic markers of volume status and perfusion. What that means is we're looking for functional responsiveness, not just hitting some numerical filling pressure.
So we're abandoning the old sort of passive approach. What are the key dynamic markers we should be watching closely right at the bedside to guide whether that next bag of fluid is actually going to help?
We should be using continuous real-time data. Look at mean arterial pressure, MEP, making sure we have adequate perfusion pressure. Monitor urine output closely. Very important. Look at lactate clearance. Is the patient effectively clearing their metabolic distress?
Yeah. Is it improving?
Exactly. And maybe most importantly, integrate things like cardiac ultrasound findings or even passive leg raise tests. These techniques tell us if the patient is still preload dependent. Will they actually benefit from more fluid?
I see.
So if the patient is unresponsive to more fluids, or if those dynamic markers just plateau, additional fluids should only be given in small increments, maybe 500 milliliters, and only when clearly indicated by that hemodynamic reassessment.
That dynamic approach, it really requires constant vigilance and access to tech like bedside ultrasound. Okay, let's shift to maybe the most time-sensitive piece, antibiotics. How critical is timing with empiric antibiotics for survival?
Oh, it's extremely important. The data here is just unequivocal. Multiple large observational studies have confirmed it. Each hour of delay in getting antibiotics in substantially increases the risk of mortality.
Every hour counts.
It's probably the single highest leverage intervention we have.
Okay, so what are the strict, non-negotiable time targets based on how sick the patient looks? This is where specificity really matters in the ED.
Right. For patients in overt septic shock, meaning they're hypotensive, they need vasopressors, broad-spectrum antibiotics must be given within a hard target. 1 hour of diagnosis.
1 hour? Wow.
1 hour. For patients who present with sepsis but aren't in clinical shock yet, the target is antibiotics within 3 hours.
That 1 hour target for shock patients, that is a very tight squeeze in a busy, chaotic ED or trauma bay. Should getting blood cultures ever delay starting the antibiotics? Is it okay to wait, say, 75 minutes for cultures if the diagnosis seems clear?
Absolutely not. Blood cultures should definitely be obtained before antibiotics whenever physically possible, yes. But they must not delay therapy.
Priority is the antibiotic.
The priority for that shock patient is getting the antibiotic molecule into their system immediately. If the culture draw takes too long for some reason, you give the antibiotics first and you document the delay. Simple as that. The clinical team can always tailor the antibiotic selection later, once cultures come back. Based on likely pathogens, local resistance patterns, the patient's specific risk factors for resistant organisms. But time is organ function here.
That really puts significant pressure on streamlining order sets, pharmacy processes, the whole system.
It does.
Okay, finally, let's touch on respiratory support. Respiratory failure is a common, dangerous complication in severe sepsis. Is there a specific strategy we can use in the ED to maybe reduce the need for invasive intubation and mechanical ventilation?
Yes, and it's a really important tool. High-flow nasal oxygen, or HFNO therapy, is rapidly gained attention as an effective way to potentially reduce the need for invasive intubation in patients with acute hypoxemic respiratory failure from sepsis.
And it's more than just cranking up the oxygen flow, right? How does high-flow nasal oxygen specifically help septic patients who are struggling to breathe?
It's really about the mechanism. High-flow nasal oxygen does two things exceptionally well. First, it improves oxygenation efficiency. Second, it significantly reduces the work of breathing for the patient.
How does it do that?
It delivers heated, humidified oxygen at very high flow rates. This actually creates a kind of positive end expiratory pressure effect, a PEEP effect.
A PEEP effect, but without needing a tight mask. That helps keep the little air sacs, the alveoli, open.
Exactly. And clinical studies show that by reducing that respiratory drive and effort, HFNO helps prevent respiratory muscle fatigue. This potentially improves outcomes because it helps patients avoid those known, often severe complications that come with mechanical ventilation.
Like ventilator-associated pneumonia.
VAP, prolonged ICU stays, exactly. All those things we want to avoid if possible.
So early use of HFNO, should that be considered maybe standard practice for the right patients showing up with respiratory distress and sepsis?
It should be considered early and, frankly, aggressively. It's a vital step in optimizing oxygenation and reducing respiratory effort before we jump to intubation, which, as we know, carries its own set of risks for the septic patient.
Okay, let's try to synthesize these essential shifts for you, the listener. We've basically established that relying on that 50% sensitive score, qSOFA, is just, well, it's outdated for screening.
Yeah, the new standard really has to be using highly sensitive tools like SIRS or new WS criteria. We've got to maximize that initial identification.
And we need to shift fluid management away from just a static initial bolus towards individualized dynamic titration based on real-time hemodynamic markers. It's physiology over a simple checklist.
Absolutely. And enforcing strict antibiotic timing. Remember, 1 hour for patients in shock, no delays for routine blood culture draws. That's a time to treatment standard we just have to hit.
Right. And finally, using high-flow nasal oxygen early in the ED to potentially lessen respiratory failure and maybe reduce the need for complex invasive intubation.
The common thread across all these updates is really a move toward more precise, individualized care, constantly adjusting treatment based on the patient's actual functional response. This shift, you see it clearly with the push for dynamic fluid markers, it changes the focus completely, away from just following rigid protocols towards executing continuous, precise hemodynamic reassessment.
And I guess this raises a pretty profound logistical question for every department director, every clinician listening right now. Given this need for rapid functional assessment, how quickly and how reliably can your unit integrate things like real-time cardiac ultrasound or lactate clearance data into continuous bedside decision-making, especially within that first golden hour?
Yeah.
That rapid access to dynamic data and the constant vigilance needed to interpret it, that feels like what really defines quality sepsis care today.